Hello everyone, this is Dr. Pal Singh, an MD Pharmacology from CMC Ludhiana, and this is my second in series for the competency PH1.13, which talks about describe the mechanism of action, types, doses, adverse effects, indications and contraindications of sympathomimetic or adrenergic drugs. And in my previous session, we had started with this adrenoceptor activating and sympathetic drugs, where we talked about a limited line of demarcation between the sympathetic nervous system and the endocrine system. Now the nervous and endocrine system are not so clearly demarcated as was thought earlier. And we talked about sympathomimetic drugs, which tend to be useful for fight, flight, or fright. In this reaction, the ultimate response that the body has is it increases the heart rate, increases the blood pressure and respiration, increases the blood through the skeletal muscles, and causes mydriasis. And this particular sympathetic nervous system or adrenergic drugs is related to the sympathetic division, where we talk about the postganglionic neurotransmitter effect of that, and these effects are mediated by noradrenaline, adrenaline, and dopamine. And any drug that mimics the action of norepinephrine or noradrenaline, both of them are the same terms, or any drug that mimics the action of epinephrine or adrenaline, both again are the same terminologies, are called sympathomimetic drugs, and they have their role in nasal decongestion, in aqueous humor formation, in shock, in bronchospasm and asthma, and also in decreased diffusion of local anesthesia. Now, these drugs, they act, or these particular drugs or these particular neurotransmitters, they act via G protein coupled receptors, and based upon some of the experiments that were done by Alquist, they were divided into beta 1, beta 2, beta 3, and alpha 1, alpha 2, and molecular cloning has further studied. Now, this particular effect, the experiment was done on arterial strips, bronchial smooth muscles, and the heart, and it was out that there are certain responses that are more there with isoprenaline as compared to epinephrine, and some responses more with epinephrine as compared to isoprenaline, and this led to the classification of alpha and beta subunits of receptors. Now, these receptors are further, the beta receptors are further subdivided into beta 1, beta 2, and beta 3. Beta 1 present in the heart and Jg cells of the kidney, causing increase in heart rate and increase in secretion of the renin, whereas beta 2 is present in the smooth muscles, causing relaxation of the smooth muscles, and beta 3 receptors is present in the adipose tissue, which is responsible for lipolysis. Similarly, we have two sets of alpha receptors, the alpha 1 and the alpha 2. Alpha 1 is present in the post-junctional effector cells, where in the smooth muscles of the blood vessels, they cause vasoconstrictions, whereas in the gut, it causes relaxation. In the heart, it leads to arrhythmia. Similarly, we have the alpha 2 receptors, which are present in the pre-junctional nerve endings and post-junctional cells in the brain, platelet, and pancreas, having a negative feedback, thereby causing vasoconstriction, decreased sympathetic flow, and insulin release, as well as platelet aggregation. Now, they act via the alpha receptors. They act via the GQ subset of G protein coupled receptors, whereas the beta receptors and the beta receptors act via the GS subtype of receptor, and beta 2 receptors, the alpha 2 receptors, they act by the GI subunit of G protein coupled receptor. Now, these receptors are regulated, and it is based upon the number of receptors present on a particular cell, and the function is regulated accordingly. And there is a phenomenon of desensitization, whereas continuous exposure to the neurotransmitter to the particular cell leads to decreased responsiveness, and this is mainly operated at the transcriptional, translational, and the protein level. And there is also a polymorphism is depicted, which causes change in susceptibility to disease, alters the propensity and response. Now, talking about the chemistry and pharmacokinetics, they are phenylethylamine, there is a benzene ring and a ethylamine side chain. Substitution of minor group increases the beta activity. Benzene ring, if it is substituted by the hydroxyl group, leads to beta and alpha activity. Similarly, alpha carbon substitution leads to prolonged action, whereas substitution on beta carbon leads to direct acting response. And these further have been subdivided based upon their action into direct acting. By that means that they act on the receptors and release them and cause further action, whereas in the indirect type of acting are they do not directly act on the receptor. They either cause displacement of stored catecholamines such as amphetamine and tyramine, or They prevent the reuptake of neurotransmitters from in the presynaptic cells, such as cocaine and tricyclic antidepressants. Whereas in the mixed group, we have ephedrine and pseudoephedrine, which act via both mechanisms. They are direct acting, that means that they can bind to the receptor and cause an action, and then they could also have an indirect effect, whereby they increase the release of adrenaline or noradrenaline from the synaptic vesicles. Now, the action of these uh, particular sympathomimetic drugs would depend upon the receptor, and it will also depend upon the relativity activity of different types of receptor. Let's say we talk about adrenaline. Adrenaline is active, uh, uh, acts on alpha 1, alpha 2, beta 1, and beta 2 receptors, whereas it acts minimally on beta 3 receptors. Similarly, noradrenaline acts on alpha 1 and alpha 2 receptors, as well as beta 1 and beta 3 receptors, but it has minimal effect on beta 2 receptors. Now we talk about the pharmacological actions of adrenaline. Now these can be divided into three actions on the heart. First, we talk about its action on the heart. It has the chronotropic effect, the inotropic effect, and the dromotropic effect. The chronotropic effect refers to the heart rate. A drug that increases the heart rate has a positive chronotropic effect, whereas a drug that decreases the heart rate has a negative chronotropic effect. Similarly, inotropic effect refers to the force of contraction. If a drug causes increased force of contraction, it has a positive inotropic effect. And similarly, if a drug causes a decreased force of contraction, it has a negative inotropic effect. And dromotropic effect refers to the effect on the cardiac impulse and conduction velocity. If any drug rate increases the conduction velocity, it has a positive dromotropic effect, and if any drug that decreases the conduction velocity has a negative dromotropic effect. Now, we talk about these sympathomimetics, they have a positive chronotropic, positive inotropic, and a positive dromotropic effect. Now, normally in the heart, we have beta 1 receptors which are maximally present. This is followed by beta 2 receptors, and then there are some amount of alpha receptors. I've already told you that these are positive chronotropic effect. That means that they increase the contraction of the heart, thereby increasing the heart rate. They have a positive dromotropic effect. They tend to increase the conduction velocity where we note, and they also tend to activate the latent pacemaker. They also increase the inotropic effect, causing an decrease in ejection time and an increase in coronary blood flow. Now, these drugs, they also increase the force of cardiac contraction, thereby increasing the cardiac output, and they tend to shorten the systole more than the diastole. Now, one of the clinical significance of these drugs is that they should not be combined with chloroform and halothane, because these two, chloroform and halothane, they sensitize the heart to the adrenergic effect. That means now the heart would have positive chronotropic, inotropic, and dromotropic effect. Now, if we talk about the action on the blood vessels have both beta 2 receptors and alpha receptors. If a drug acts on the beta 2 receptor, it causes a smooth muscle relaxation. If a drug acts on the alpha receptor, it causes vasoconstriction. Now, the response will ultimately depend upon the vascular bed, the dose, and the drug. Now, it is the alpha receptors, they regulate the tone and increase the arterial resistance. They are present in the skin, renal, and splanchnic vessels, whereas beta 2 receptors are present in the smooth muscles, and they cause dilatation of skeletal muscles as well as liver. And dopamine 1 receptors are present on which cause vasodilation of renal, coronary, and cerebral splanchnic vessels. So action is more marked on the blood vessels. Now, supposedly we talk about a drug that is a pure alpha agonist. This drug is a pure alpha agonist. What it will do is it will increase the peripheral resistance and decrease the venous capacitance. Whereas a drug which is a pure beta agonist, it will increase the cardiac output, increase the systolic blood pressure, and decrease the diastolic blood pressure. Now, talking about noradrenaline, if we remember, we have in the previous slides I told you that noradrenaline acts equally on alpha 1, alpha 2, beta 1, and beta 3 receptor, whereas it has minimal activity on the beta 1 receptors, that the beta 2 receptors that are present in the blood vessels. So it causes an increase in systolic blood pressure, diastolic blood pressure, and mean blood pressure. Isoprenaline is a selective beta agonist, so it will act specifically on the beta 1 and beta 2 receptors. So it increases the systolic blood pressure, decreases the diastolic blood pressure significantly, and also decreases the mean blood pressure. Now, the situation is tricky when we talk about adrenaline. The response of adrenaline would vary depending upon whether we are giving it by slow infusion or subcutaneous injection, or we are giving it by the rapid IV injection. Supposedly, we give it by slow injection or subcutaneous injection, that it tends to fill up the beta receptors first, followed by alpha receptors. So once it fills up the beta receptors, it causes a decrease in systolic blood pressure, a decrease in diastolic blood pressure, there is a decrease in pulse pressure, and an increase in mean blood pressure. Whereas if we give it a rapid IV injection, it tends to fill up both alpha and beta receptors. So it increases the systolic blood pressure drastically, increases the diastolic blood pressure drastically, but it tends to normalize within a few minutes, and there's a secondary fall in the mean blood pressure. Similarly, there is another phenomenon that is there, that is the vasomotor reversal of trail, which is normally shown when we give adrenaline, which acts on the beta receptors, causing a fall in BP when if it is combined with various alpha blockers. Now, this is the effect of these drugs on the arterial blood pressure. We talk about adrenaline, we talk about noradrenaline and isoprenaline. Now, you find that adrenaline increases systolic blood pressure, decreases diastolic, and increases the mean blood pressure, whereas noradrenaline increases all of them, the systolic, the mean, and diastolic, whereas the isoprenaline, it increases the systolic blood pressure, but causes a decrease in mean blood pressure and diastolic blood pressure. Similarly, we talk about out here, there's a decrease in peripheral resistance on intake of isoprenaline. Action on the respiratory system. Now there is beta 2 receptor that is present in the smooth muscles of the bronchus. So predominant beta receptor are present, which leads to smooth muscle relaxation, causing bronchodilation. Now the upper respiratory tract has alpha receptors, and these alpha receptors cause vasoconstriction, thereby causing decongestion. Adrenaline also has the propensity to directly stimulate the respiratory centers, whereas a toxic dose of this could lead to pulmonary edema. Talking about its action on the eye, we have alpha 1 receptors, which causes contraction of the radial pupillary muscles of the iris, thereby leading to mydriasis. Now, this is a direct acting action of mydriasis. Effect on the aqueous humor, we have alpha 1 receptor, the alpha 2 receptor, and the beta 2 receptor. So, if we talk about the alpha 1 receptor, now in the alpha 1 receptor, there is vasoconstriction of ciliary muscles, thereby reducing the formation of aqueous humor. The alpha 2 is responsible for negative feedback. It reduces secretory activity of ciliary epithelium, whereas beta 2 acts in the opposite direction of alpha 1 receptors, causing enhanced secretory activity of ciliary epithelium. So when we talk about glaucoma, we can give an alpha 1 agonist, an alpha 2 agonist, but a beta blocker should be given. Adrenaline does not penetrate the cornea, so instead of adrenaline, dipiventrin is given to take care of this particular action. It gets converted into adrenaline. In the GIT, we have the beta receptors, which causes the relaxation of smooth muscles, and we have alpha 2 agonist, which decreases the muscle activity, and it also decreases salt and water influx into the lumen of the intestine. So the overall effect is there is decreased peristalsis and constriction of sphincters. The exocrine glands, it causes regulation of secretion of salivary gland and sweat gland. In the genitourinary tract, it is present in the alpha receptors present in the base of the bladder, which tend to hinder micturition, whereas beta 2 receptors are present in the uterus, and the action would depend upon pregnancy and species. In the skeletal muscles, it tends to increase the neuromuscular transmission facilitate, and in the red muscle fiber, it causes enhanced firing, thereby leading to tremor, where in the white muscle fiber, it prolongs the active state and increases tension development. We talk about the metabolic effect. The beta 3 receptors, they were present in the adipose tissue, causing lipolysis, and it also tends to enhance the glycogenolysis. That means that they're trying to increase the blood glucose level and decrease the blood glycogen level. They cause metabolic acidosis, they promote the uptake of potassium, and alpha 2 receptors also regulate insulin. In the CNS, although we don't have any direct effect, but the effect could range from nervousness to feeling of impending disaster, and these are the symptoms that are related to anxiety. Now, talking about the administration and preparation of adrenaline and isoprenaline and noradrenaline, all these drugs are inactive orally. Adrenaline is used in the dose of 0.25 to 0.5 milligrams subcutaneous or intramuscularly, and the local vasoconstrictor, which is given in the dose of 1 into 2 lakhs to 1 in 1 lakh. Isoprenoline is given in the dose of 20 milligram sublingually, 1 to 2 milligram IM, IV, or infusion. Talking about the adverse events are basically an extension of the pharmacological action. So what happens is it tends to precipitate cardiac ischemia and failure. It causes sinus tachycardia, ventricular arrhythmia, and myocardial damage. It also leads to restlessness, insomnia, anxiety, paranoid state, tremor, and marked rise in BP. So these drugs are contraindicated in hypertensive patients, in hyperthyroid patients, in angina, and they should not be combined in patients who are taking halothane and chloroform as well as beta blockers. So this finishes our topic of adrenergic drugs. And now one of the components that is left, which I will be taking up in my next session, is the therapeutic classification and individual drugs of the sympathetic nervous system, which we tend to often use. I hope I have been able to clear some air on this particular concept, and if there's any queries, do let me know. I'll be very happy to answer them. I am thankful to all of you for your patient hearing, and I hope you have had a good learning. So it's nice. Thank you all for your patient hearing, and wish you a great day ahead. Thank you so much.